Funded health and dental insurance plans, funds and funding levels, plan design, and premium contributions. Ms. Grill.
Rebecca Grill, City Administrator, joined here with Rayanne and Alex Beaudry from Horton, and then Peggy Steno, our Finance Director. We've been working with the Employee Benefits Committee for the last couple months, trying to come up with some ways to mitigate the current challenges we have with our self-funded benefit plan, and we wanted to bring to the council kind of the challenges and some of the opportunities, and this is just the first meeting. We'll have a more in-depth meeting next Monday at 5:30, and then probably some other subsequent meetings depending upon how things go. But we just wanted to talk to the committee in addition to the Employee Benefits Committee that we've been meeting with. So I'm going to hand it over to Alex.
Thanks. So this is designed to be a high-level overview, but please feel free to stop and ask questions. I really want to talk about a few things. First, to start with healthcare trends as a whole. I'm sure you're all well aware, but medical trend in our area is about 6%. So if we don't do anything year over year and we have the same amount of claims, we would expect the city's claims year over year to go up by 6%. Pharmacy trend is almost 15%. So given everything that you as a city have to do from a budget standpoint, knowing that we're looking at just from starting from zero, a 6% increase year over year, that obviously presents some challenges. The city of West Allis has some specific trends. The first is an aging population. Rebecca, we were in a meeting with her earlier today, and she mentioned that 30% of your non-reps are over the age of 55, and 45% of them are over the age of 50. From a healthcare risk standpoint, as individuals age, healthcare costs increase. I mean, just your standard physicals once you reach a certain age become more expensive. Colonoscopies are $5,000, mammograms are thousands of dollars. So we have to watch that. I already talked about trend. Claims from the city's standpoint, just over the last few years, have also spiked from a utilization standpoint. So what we're starting to question, is this a new normal? Claim cycles tend to go every 3 to 5 years, where we'll be on an upswing for 3 to 5 years, and then we'll be on a downswing. We very much seem to be in an upswing over the last few years, so that's something else we need to manage. And then lastly, from the city's standpoint, we have very high claims utilization, in part because we do have such nice benefits here at the city. Over the last few years, we've made some very significant changes to the benefit plan. For example, the Medicare Advantage plan. We implemented a new pharmacy benefit manager that we projected to have great savings. And then even before we were your consultant, you implemented the Narrow Network with Aurora. Those are all significant changes. However, none of them impacted plan design or curbed utilization. So they were big savings, but they were one-time savings. Now everything's kind of catching up with us in this claim cycle, so we need to manage that. So some different strategies. There's different ways to cover risks, and I think everything's on the table. So our goal over the next several weeks, as we come back to you, is to give you options to help curb this, to help manage the budget. The first is premium contribution. This was already approved in the new budget with the premium increase. I bring it up because it is a strategy to help the budget. However, it doesn't curb utilization. Premiums are like a movie ticket. It's just the price of entry. It doesn't change any behavior or incentivize any behavior changes. It really just kind of helps fill a budget gap. The next strategy would be plan design. Again, you as the city have a really nice benefit of like a $100, $300 deductible. We work with almost 40 municipalities and school districts. We don't have any other municipalities that have a $100, $300 deductible. It's just over the years, as budgets have been hit, those are the first things that have been changed.
In fact, as I look at surveys that are available at Repelra or WASBO for the school districts, et cetera, there are no municipal or public employers that have a $100, $300 deductible and then 100% coinsurance. It's just really unheard of. And I realize for the city, this was a mitigation factor when you went to the Narrow Network. But again, those savings are now that one-time deal bringing us down. We're sort of crawling back up there with the claims utilization. So.
And with the Employee Benefits Committee, we're also exploring other options that we'll bring to you, including co-insurance and co-pay tweaks, all designed to help increase consumerism and better decision-making through your health plan. Another strategy is, and I'm going to say it's a little bit tongue-in-cheek, is to get younger. Obviously, we can't fire all of the older population. That's certainly not what I'm suggesting, but there are a couple different ways to potentially do that. So one, can we set up an alternative plan design to help attract younger talent? Not everybody in your population, I would assume, wants a $100 single deductible. Can we offer multiple plan designs that may attract someone of a different generation to come work with the city? And then second is wellness. It's something that the city has taken very seriously and something that we're looking at bolstering in the future. Can we get our population, even though their actual age won't go down, can we get their health age down? Can we help them make decisions where, even though I may be 50, my actual health age is like 47, as an example. Humana does a great job of tracking that, and we look to bolster that program as a strategy. The last strategy, before I turn it over to questions, would be to reduce risk or exposure. Can we incentivize or create opportunities for employees and their families to leave the city's health plan, but also have a better benefit? So one example of this is a family savings plan is what it's called, through Network Health Plan. And what it does is it would incentivize your employees to take their spouse's health plan if they're available to them through another employer, and they will, not only would the city then pick up any premium differential, they would help pay for any out-of-pocket expenses. So co-pays, deductibles, co-insurance. So even though I am now off the city's health plan, the city is going to help me pay for those bills. So it's much different than like a spousal surcharge or a carve-out where that's more punitive. This would actually be a richer benefit and incentive that not only am I, being encouraged to leave, but I'm in a much better position financially.
And that risk is limited because you'd be paying only the differential of what they pay today versus what they would be paying at a new employer. So if I'm paying $200 a month and my spouse is paying $300 a month, it would be that $100 delta only. And then the exposure on any sort of claim is also limited by the maximum out of pocket, which is mandated by federal law. So you're only paying claims, A, if they're incurred, and B, if they are, you still have a maximum risk line in the sand. So what this does is, if you finally have a way, because people always ask, well, why don't you pay me to get off your plan? Well, the reality is when you pay people to go off your health plan, cash in lieu of benefits, what happens is you lose all your healthy people because your sick people are going to stay on the better plan. Well, now, doing this kind of risk mitigation, I am able to make the spouse's plan the better plan because it's 100% coverage to their out-of-pocket maximum. So, and it's all tax advantaged for the city of West Allis because you're paying the providers directly, so it's still considered a medical expense. So it's a third plan offering, if you will.
So in summary, we just want you to know that we're working on a lot of different options. We're working with the committee, and in subsequent meetings, we'll have much more data points with actual numbers behind them. But we wanted you to be aware of what we're working on, so it's not a surprise when we ask you to vote, that you actually have some time to kind of think it through and ask questions and those types of things. So unless you have anything else to add.
Well, I would just add a couple of things. I know it's the first week in December, but open enrollment is a month and a week away. So some of these decisions obviously are going to need to be made relatively quickly. With what's going on with the claim cycle, I think not only have your claims been going up, maybe because we have a slightly older population, which again isn't unusual, and we have a lot of retirees between 55 and 65, and they're getting stuff taken care of. As we age, we need it. The hips, the knees, the rotator cuffs, all of those things, even if they're elective and fairly mild, they're still at cost increases. So we're right now in sort of the conundrum of we don't have a lot of shock losses, for lack of a better term. Our high cost claims are $500,000. Those are actually substantially reduced right now. We're doing well there. It's all the $55,000 to $105,000 claims that are really starting to stack up, and some of that's coming from prescription drug services alone. So the mitigation and the ability to maybe reduce our exposure and have some of these people voluntarily choose to leave our plan and be in a better spot for themselves and for the city is really viable, because we're stuck between technology right now. Technology and claims. People can get new parts. And they can be made to feel, or they can be made to live with disease much, much longer. So we want to take care of people's health and we want to do the right things, but we also need to be respectful of a budget and the ability to continue to attract and retain and do the services the city needs to do.
Yeah, and so just to clarify, these are just things to talk about at this point. There's no formal recommendation, nothing formally before the council yet, just something to talk about.
Just really wanted to bring to light some of the challenges, and I don't know if you mentioned about our fund balance and things like that. That's really,
Mr. Chair, that's what I was going to ask. So what's the problem?
it's taken a significant hit over the past years, because as Alex says, we made changes, but they didn't make any significant,
We didn't bend the utilization curve at all.
not at all.
In fact, we seem to increase it.
Yes.
So, yeah, exactly, and that's not to say we didn't save money from those changes, we did save a lot of money. We would be in a much worse situation right now had we not had a new pharmacy benefit manager, and had we not moved our post-65s to the Medicare Advantage plan and not gone to the defined network. But our claims, our utilization just keeps going, so our fund balance over time, I mean, it's dropped a lot. We're expecting this not to be any better year. We keep saying, oh, in 2017 we had a bad year. We had that same bad year in 18. Only in 18 it was really
Worse.
bad. 2019 is not looking a whole heck of a lot better. So we still have a fund balance. We're not, tapping into the general fund balance or anything like that. But we can't go on like this and have utilization as high as it is today, and the city paying for as large of a portion of the cost as it is today, and still be successful with our self-funded plan going to the future.
Mind if I just
Sure.
ask a bunch of questions?
Go ahead.
What is our fund balance now, and where are we projected to be at the end of next year?
So our fund balance going into 2019 was 4.4 million.
Oh, going into this year, okay.
We only have 6 weeks, but let me tell you, it's not been a good year. Originally, 2 months ago, we were looking at like around $100,000 loss. Now, sitting here before you today, seeing what the claims have been in the last 2 months and what they could be for the rest of the year, drugs and medical, we could be taking a 900,000 or more hit.
And that's kind of an interesting thing, because in the year where you have a bunch of the big time shock losses, you get stop loss reimbursements, we get money back. And that's mitigated some of those difficult plan years. Now we don't have many stop loss reimbursements because we don't seem to have any of the really giant claims. And by the way, that's another thing to look at, is where do we set our specific deductible level, because we did bring that down $100,000 when we came on board. Maybe it's time to maybe look at something that's even lower, so we mitigate that risk from 175,000 down to maybe 100,000.
That's the stop loss.
So yeah,
That's
so
stop loss.
basically, any claims up to 175 are ours, anything over 175 is our extended risk.
So if we have a bunch of them in the 50,000 to 125, that's all on the city right now.
And we have a big list of those.
So we're down 900,000 approximately on the year. That fund balance going forward, if that continues this trend, hypothetically, we do nothing 4 or 5 years and that balance is gone.
We don't have a self-funded plan anymore.
And then what?
Quicker than
Then
5
we'd have to
years.
go fully insured, and we'd be basically, and then if our claims utilization was high, we'd be looking at these large increases every year. There's no, you can of course change the plan, but you couldn't even find a plan out there right now in the fully insured world like our plan.
And we would have to do significant things to stay in our expenditure restraint and levy limits to afford moving from a self-funded to a fully insured plan. So that would be probably significant cuts in services and personnel. So that's why we don't we're coming now, we want to be proactive.
So not everyone understands the idea of expenditure restraint. I think we do because we're on this committee. Can you explain it so other people listening? As simple as you can. Basically, the state says we currently have this much that the city spends, and next year we're only allowed to increase it by a rate of inflation plus perhaps a bit of growth that we see in the city, correct?
Correct.
And that's our ceiling. So everything the city does must be funded within that
Right, in order for us to get the payment.
in order for us to get
the
close to
expenditure.
$1.5 million from the state.
Right.
So
So this year, we were only able to go up $1.455 million.
and we did that mostly through salary.
Correct.
Increases.
Yes. And a lot of it was the represented salaries. So if we keep going that, we won't be able to afford these increases in health insurance. Because when the premiums go up, not only does it go up for the employees, it goes up for the city too.
Yeah.
So
So it's not just, we've got this problem with insurance costs going up. The problem is we can't go to the taxpayer for the extra even if we wanted to. Unless we wanted to burden
you
a
would have,
substantial amount, $1.5 million, just to overcome that first dollar above and beyond
Right.
expenditure restraint.
And something that Peggy mentioned earlier about, if we continue on this trend, we have to get out of the self-funded world from, I think, unless you have a different opinion from where we sit, that's not a viable option. Because you go from a small piece of risk that you have today, plus claims, to fully insured that is a guaranteed expenditure. And fully insured claims do not come back down, or not claims, premiums do not come back down. So if you're paying $12 million roughly today in premium equivalents, next year when you're fully insured, that's gonna be 12.5, and the year after it's gonna be 13. There is no coming back from that. So not only will you have first year costs of trying to change from self-funded to fully insured, it's too much of a burden if we're already having these types of budgetary constraints. So from where I sit in my chair, I couldn't recommend that. So we have to get our utilization and our costs under control, because I don't see that as a viable option for the city.
And if you wait, to Alex's point, if you wait to do it until you absolutely need to do it, you won't find a buyer. It'd be, 25, 30% rate increases, and you still have to pay your run-out claims and the cost of administration, because those claims that have already happened aren't gonna be covered by the new fully insured carriers. So we have to get this under control faster than, it's not even only a fund balance issue, it's an issue of how are we going to keep this a viable and exciting offering where you're still substantially above average in the public sector, so you can attract and retain, but it's affordable.
So that gets my next question then, Mr. Chair, is are we going to see some comparables for our comparable cities? Are we going to see what do they have? I mean, I want to take into account the whole benefit. We look at salary and we kind of consider it healthcare. It's all one big compensation package. Are we going to be able to see what the other cities
started
have,
putting some things
salaries?
together with, I was looking today at the state, the county, and the city of Milwaukee, and so we'll have, and then our other comps. Just
We had many of
surrounding
those a
areas.
couple of years ago
Yeah.
for the committee, if
In
you'll recall, we showed
20
your comparables, I think we just have to update that.
2017, we had that. We had a survey done with all of our close comps, so we can update those. At that time, the deductible level, we did have a few, we shared under $500 with a few people, La Crosse, Janesville, Oshkosh, and Menominee Falls, but they were probably not 100 and 300.
They were not
Maybe
100.
three of the four
They were
are
400,
going
La Crosse is 400 and 800, because I work with them, and then they have 90/10 co-insurance after that. The Village of Menominee Falls was just forced after a 23% rate increase. They are fully insured. They went from a $250, $500, 100% to a $1,250, $2,500 deductible, 90%. So it's a significant change just to meet their budget of 14%. So similar stories with both of them, and it's healthcare costs are going up.
Mr. Chair,
Alderman Weigel.
if Alderman May's done.
Yeah.
No silver bullet here, I see, in a list of like 6
Not yet,
different
we're
options.
trying.
No, I get it. I understand that. I guess on the multiple plan thing, I thought we were moving towards fewer plans that we were offering for simplicity's sake. And I understand the idea, but that's gonna make it more complicated
From
for
that
us.
standpoint, the city, when we began working with you, had like 56 plans, and they were all
Yeah.
very unique based on date of retirement. This is much more generally like everybody would have a choice between 1 or 2 plans. I'm not talking about adding
Okay, you're not adding like
12
7 or
plans.
something.
No, this would be,
Okay.
okay, we have our very traditional PPO plan, maybe the high deductible health plan option that we're offering.
Mm-hmm.
Maybe that's not a narrow versus broad network decision, maybe it's a true deductible decision, where maybe the same network, but I take either the 100, 300 plan, and then maybe I take a $1,300 HSA plan. Just as an example. Obviously, we have to vet that through, we have to make sure it makes actuarial sense, because the last thing we want to do is artificially reduce the premium, and then we still have the same amount of claims, because that just puts us in a bigger budget hole, so that needs to be explored further, but things that we are exploring.
And I assume that we're gonna look at this, getting people to go on their spouse's insurance. We're gonna have an idea of, is that data we already have from our
Piece of
employees?
it, we're looking to get it, well, we have a estimate on what this would look like. We're going to give the folks at Family Savings Plan a little bit more data that we have, so that they can do a little bit more, likely baseline.
Right.
In 2018, we did a survey of employees, and we had 300 respondents, and at that time, there were 43.17% of those people took our insurance because it was better than their spouses. So of the 300, you would guess that at least 40% of them, their spouse has some type of plan. And this plan, as we learn more about it, it's a win-win for the city and the employee, because basically, we'll find out more next week, but it's not anything more out of their pocket. It's actually, in some cases, could be less.
Well, and as we look to what we potentially might think about change, we're being very mindful, as we go through this with the benefit committee and even with the actuaries. It's not just change to make a change. It's what changes will actually drive a different behavior. So if for example, you do something different with office visit copays, and suddenly you introduce telemedicine, and you do a real big push around that, and they can get that for $0 cost, do some people change their behavior now and start to use virtual visits? So there's all kinds of, we're not looking to just do something's sake, but the reality is once I'm past $100, which basically takes a ripped nail these days, it's Katie bar the door. So we have to look at what's reasonable. Even Medicare has increased their deductible on Part B from $100.
The state plan no longer has any plans that look like what the city has. They have all increased to, I think, a minimum of at least $500. Some are even higher than that, so even the state's moved away from it.
Mr. Chair.
With me.
So I see our problem is kind of threefold. We've got the depleting fund, which we need to keep going. Expenditure restraint, which if we're going to absorb it through, taxes, we'd have to cut services and staff, I would guess. And then the third problem being employee retention and attraction. I don't think that we want to have a mass exodus, and we want to take care of our employees, of course. We cannot incentivize people who are over 65 to use Medicare, correct?
We can't.
Okay. And education, are we doing enough with education? It came to my attention that there are still some employees who believe that, and retirees, that if you want to ride to the hospital, the fire department will give it to you for free. That does not exist. That costs the city a lot of money.
Well, it used to exist.
Yeah, used to a long time ago, right?
Oh, not that
couple
long
months ago.
Up till a couple months ago.
You're kidding me.
No. So, it came to my attention too.
Wow.
But yeah, we've talked about things like that. I have been going, we're not doing enough education. I think we would all agree that we would like to get to your employees more, and there's a couple of different ways we're looking at drip campaigns and how do we get to them. One of the challenges, of course, is we have meetings and people don't always choose to participate. So we'll have to tackle some of this during open enrollment. Obviously, we'll have to make some time for some one-on-ones. So
There are
One
services where
thing-
you can call in. I'm sorry.
Sorry to cut you off, Alderman May. One thing that we did talk about that was built into next year's budget that I'm going to propose the city strongly consider is a mobile app called HealthJoy.
As I was just going to ask about. Okay.
They're a third-party vendor that runs a mobile app. It's about $6.50 PEPM per employee per month, sorry, that the city would take on that cost. And so then it would be free to your employees to use. And what this app does is it's like a personal concierge for medical services. So if I need a knee surgery, I can go to the app and they can set up that appointment, make sure that I'm going to an in-network provider and I'm seeing the best provider based on cost and quality outcomes. Same would be true if I need a prescription. They can tell me which provider in the local area, Walgreens versus CVS versus Walmart, would have the best cost for those
So
medicines.
you're on the Look Good RX?
Yeah. If I have a service that I need like urgent care services for, so I'll use my son as an example. He gets croup like 3 times a year, it seems like. I go on the app and I say, hey, this is what I think's going on. Can you help set an appointment? The app will ask me, do I think this is something that telemedicine can do? Yeah, probably. So then they'll give me a link right on the app as I'm talking with AI, and I click on it, and that's now free to me to use. And it's a $49 visit versus a $175 urgent care visit that the city's paying. So that's where you get the return on investment. The other great part about this app is it has a benefits wallet, so it contains all of the city's benefit information. So if I don't know how my benefits work or how much my deductibles met or my EOBs, all I have to do is click on the app and all of that information is stored in there. And the city can do up to 4 push notifications sent every year. So as technology gets better, email gets less effective. If that makes any sense? I don't know about you, but I use my employer kind of tongue in cheek. We get a Monday morning email communications. I delete that email as soon as it comes in my inbox. I get a text message, I'm going to answer to that, or at least look at it as my phone vibrates. So can we use that technology to better communicate with your employees? Say, hey, we have a wellness fair coming up. Can we push that out via text message? Or the app itself, if I'm not using or engaging in it, they'll say, hey, don't forget about us. Have you sent your primary care visit for the year? Just those touch points every year so that we're not just communicating with your employees around open enrollment. They're hearing from the city every 4 to 6 weeks. So it's really cool technology. I'm going to set up a demo with the city. It's an expense that Peggy and the city has budgeted for. So I'm really excited about it. I think it can help with education and consumerism and all of those things. So
But if you were in line, I mean, think about the ability to do something just as strange as you're in line at a theme park in Florida with your kids, and somebody says, "Hey, I'm starting to get a little bit of a sore throat." Hit on the app; it'll literally make you an appointment through the virtual visit if you can do it, or give you GPS directions to your nearest in-network provider. That's low cost. So maybe it'll say, hey, did you know there's a Meijer right down the road here and they have a quick care or a fast care clinic visit. This will cost you $10. Here's GPS instructions on how to get there. So just different things. This is great for people who are on the road a lot. Think of your public works folks. And what I think people forget about with virtual medicine in particular is that you can actually set your appointment. So if I'm thinking about it right now, and I go ahead and I can say, my break is in an hour. Can I have, so for example, if this was 8:30 in the morning, my break's at 10 o'clock. Can I have a meeting with the virtual visit at 10:05? That's when the virtual visit will call me back. That's when telemedicine will call me back. So I don't have to do it when I'm in the middle of a conference or something. So it sets all that for me. People like having a concierge. People like having somebody or something do it for you.
That's called HealthJoy.
HealthJoy, yes.
So I think a lot of time, again, the terminology in healthcare is very difficult.
Oh, sorry.
No,
If I use acronyms.
no, I understand it because, through doing this, I understand it, but I think when people hear telemedicine, they think they're talking to a computer. You can get on and speak face to
Virtual
face.
visits are only face-to-face, so it's through your
With-
smartphone, yep, a tablet, a computer, yes, and it's
And
with
it's-
an MD.
Licensed physician.
Yep, or a nurse practitioner, right?
No.
Never
They're all
a nurse
MDs.
practitioner. Because in order to be able to e-prescribe, it has to be an MD.
In the United
My wife's
States.
an NP,
Yeah.
she could prescribe.
She can prescribe in
Person.
Wisconsin.
Okay.
In person. She cannot prescribe over the web.
But whenever I do a visit virtually, they ask me what state I'm in. And I'm going to get a licensed provider, medical doctor in that state, that's licensed in that state, so that they can send my prescription to the nearest pharmacy, wherever I'm at.
I
If you have an
literally-
earache, instead of sitting in an urgent care, which is gonna cost all of us more, the employee more pain sitting in that emergency room listening to everyone else with their issues.
I've literally pulled off into a wayside, had my virtual visit and said I'll be in La Crosse in 10 minutes, and I've sent my prescription to the nearest Walgreens.
Or if you have kids, the last thing I want to do is take my 15-month-old son at 10 o'clock to a children's urgent care and wait for an hour to see a doctor. Like, I can do a virtual visit on the spot, he can go back to bed, I can go to Walgreens and pick up his prescription. So it's not only convenient, it's cost-effective, and it does all the same things that urgent care can do. So how can we utilize technology to help with these issues as well? Any other questions?
Yeah. All right, well, thank you very much.
More to come in the next couple weeks.
Yeah,
Stay
yeah.
tuned.
Merry Christmas. All right, anything else properly come before the committee? Have a motion to adjourn?
So moved.
Second.
All in favor, say aye.
Aye.
We're adjourned. All right, thanks, everybody.
A lump of coal would be welcome, all right?